Hello, and welcome to the podcast that I've prepared for the IHI Chapters in the UK. Firstly, thank you for your interest in improvement in quality and particularly in sepsis. My name's Ron Daniels. I'm an intensive care doctor in the West Midlands, and since 2005 I've been campaigning, researching, lobbying, raising awareness to try to improve outcomes from sepsis. And that's why I'm delighted to have a chat with you today. So sepsis is a huge problem. As an intensive care doctor, it's our bread and butter. It's the most common reason for intensive care. It's also the most common reason for deterioration in hospital. And we, working together, have opportunity to save many thousands of lives each year. As you all go through your professional careers, you will see sepsis frequently. Those working in the community, perhaps general practitioners, will see it less frequently, of course, than those in hospital. But we all need to be aware. Working together with that culture of awareness, the ability to recognise sepsis, the ability to intervene quickly and to escalate to our seniors as soon as possible, will save many thousands of lives. It's also a cost-effective quality improvement. Sepsis costs the NHS an estimated £2 billion per year. And we also estimate that if we get the basics right, we can save about 170 million of that expenditure each year. So it's good for patients and it's good for our budget. I'm just going to show you now a few slides to detail, firstly, why I got involved, and secondly, just how big a problem this is. So this is Jem on the left and Karen on the right, and their children Tom and Emily between them. It's a grainy photo because it was taken a few years ago and it's a scanned image. But 2 weeks after this family holiday, having completed their family, Jem and Karen decided Jem was going to have a vasectomy. So he came back, GP did a vasectomy, it all went straight forward. Jem was a company director. He was a strong man, a fit man, perhaps he doesn't look it here, but he was a competitive water skier, motocross rider. He loved life. The day after the vasectomy, he took himself off to work and he came back early. It was the first time Karen had ever known he'd come back early. And he became progressively unwell. Initially flu-like symptoms, which is so common in sepsis. He took himself to bed, felt lousy, tried to drink water, took some paracetamol. But the following morning when he woke up, Karen noticed that it was like he was drunk. He was slurring his speech. He couldn't get out of bed. She described him as looking like an old man trying to get up. He got worse and worse. Karen called the GP, who attended him, and said, well, yes, you've probably got flu, but just in case it's a wound infection, take this amoxicillin. Of course, Jem was vomiting by then as his sepsis had progressed, and he didn't keep the amoxicillin down. The next morning, Jem looked awful. His lips were blue, his skin was mottled, he was barely conscious, and Karen called 999. They transported him to hospital, whereupon he had a cardiac arrest in my emergency department. I came on duty and found this young man lying in bed on maximum intensive care therapy and deteriorating despite all we could offer. I remember as clear as it were yesterday, walking down the hospital corridor, following Karen, knowing I was about to take her into the relatives' room to tell her that her strong ox of a husband wasn't coming home, and that she was going to have to come home and explain to Tom and Emily why Daddy wasn't coming home, and all from a condition they've never heard of. There are 37,000 stories like Jem every year in the United Kingdom. This is Villa Park, taken a couple of years ago. You can tell that because it's full. But when Villa Park's at capacity, it holds about 38,000 people. Every one of those tiny dots in that photograph is a person, with a family, with a story, perhaps with children, perhaps with parents, perhaps with loved ones. I just use this image to bring the scale of this problem home. The North Stand at the top there holds about 8,000 people, and that's about how many people die from breast cancer every year in the United Kingdom. The Trinity Road stand there holds about 15,000 people, which is about how many people die from bowel cancer every year in the United Kingdom. As I've said, the capacity of Villa Park is about 38,000. And 37,000 is the annual number of deaths from sepsis in the United Kingdom. That's more than breast cancer and bowel cancer and prostate cancer put together. Now, of course, if we couldn't do anything about this, then there wouldn't be any point me speaking to you now. But we can. We can save many of these lives, and we estimate we can save at least 12,500 more lives every year. Now, some of these survivors do relatively well. You could argue that the individual on this slide has done moderately well since surviving sepsis. She's free of psychological problems, physical problems as a result. But of the 65,000 or so survivors of sepsis, many of them have long-term problems. This slide talks about cognitive impairment, and you can see that about 17% have long-term moderate to severe cognitive impairment after sepsis. There are other issues that people face. Post-traumatic stress disorder in about 20%. The hair falls out, their fingernails are brittle, and this distresses many patients. And of course there are the physical sequelae that in some are rare, like the amputation of digits or the amputation of limbs, particularly in meningococcal or pneumococcal sepsis. But a lot of people suffer long-term fatigue, muscle pains, joint pains. Surviving sepsis, particularly if it's left to the severity whereby people need intensive care, can leave people with long-term problems. We need to fix this. We can fix it by getting the basics right. And as you progress through your careers, you will have opportunity, firstly, to contribute to the delivery of this basic care, secondly, to lead the delivery of the basic care, and thirdly, if you end up in an acute speciality or in critical care or emergency medicine or one of these other specialities, then you'll be able to move on from this and deliver advanced care for the people that the basics don't help. So what are the basics? Well, the basics in the UK, we use a concept of the Sepsis Six. These are 6 simple, evidence-based therapies that any junior doctor working with any junior nurse can deliver to the patient. Giving high-flow oxygen, taking blood cultures and thinking about where the source of sepsis might be and controlling that source. Giving antibiotics according to local protocol, starting proper intravenous fluid resuscitation. I don't mind whether you use Hartmann's or Plasma-Lyte or in small doses initially normal saline, but we need to get at least 20 to 30 mils per kilogram body weight into the patient if they're hypotensive at presentation. Measure the lactate and start accurate hourly urine output measurement. These can be delivered in any ward setting, increasingly can be delivered outside hospital, and can be delivered by junior staff. If we deliver them within 1 hour, then we significantly increase that patient's chance of survival. And if they're not improving after that, we need to get critical care down to complete this thing we call early goal-directed therapy, which is outside the scope of this little podcast. Here's the crucial thing. For every hour we delay in administering antibiotics in septic shock, the risk of death increases by 7.6%. If you're working in a hospital, think about that. You prescribe an antibiotic, it might be 4 hours before it's given, even if the patient's critically ill. Unless we take prescriber accountability, for example, in administering antibiotics, we're not going to win. So, next time you're involved in dealing with a septic patient and the prescriber prescribes an antibiotic, just ask yourself, is that antibiotic going to be given? Does the prescriber need to give it, or does he or she need to delegate the task to an experienced nurse who knows how urgent that is? As I've said, you'll all meet patients with sepsis. You'll meet them in a variety of settings. And this slide highlights a BBC report recently that showed that doctors are failing to spot sepsis. This arose from an ombudsman's report that was released in September of 2013. We don't need the Ombudsman, we don't need the BBC to tell us we're poor at this. A recent College of Emergency Medicine audit found that even in emergency departments, we're delivering antibiotics to people with sepsis in the first hour in only 33% of cases. If that's the case in emergency departments, how badly must we be doing on the ward? With antibiotics being the single most important thing to save patients' lives, we have to fix this. We examined the Sepsis Six a few years ago, and we found, although it was only an observational cohort study, we found some fairly striking results that have been borne out since in other studies in this country and abroad. Over an improvement programme, we showed that compliance with the Sepsis Six and compliance with a more complex resuscitation bundle increased as we progressed education and as we rolled out the programme. Mortality appeared to fall, and when we looked at this, we found that those that achieved the Sepsis Six with severe sepsis or septic shock had a 20% associated mortality. Those that did not had 44% associated mortality. Now, of course, it's a bit naughty to put in a number needed to treat there, but if we believed that the Sepsis Six was the thing that made the difference, and for the life of us, we couldn't fathom why we shouldn't believe that, because the groups were similar for time of presentation, severity of illness, comorbidities, sex, etc., etc., then we need to do the Sepsis 6 to 4 patients to save 1 additional life. It's a striking improvement in outcome just by getting the basics done. I mentioned other studies. I'm not going to go into the science in great detail, but this is one interesting one recently across 11 hospitals in the USA that found that by delivering a care bundle extremely similar to the Sepsis 6, patients did not need intensive care. Patients did not need the more invasive aspects of the Surviving Sepsis Campaign's resuscitation bundle. They got better, and that's what we found. And that's the message we want to get out, that if we deliver the Sepsis 6, we can limit the severity of illness, prevent the need in many patients for critical care, and not only save lives, but by critical care avoidance, reduce many of those long-term complications that people face. This was the same gentleman, and this was 24 hours after I admitted him through the emergency department. He just got the basics. The astute among you with good eyesight will see that he's got a central line in there, but he didn't actually need it. He never needed vasopressors. We gave him fluid challenges, antibiotics, delivered the Sepsis 6, and he bounced back. And 2 days later, this elderly gentleman who had severe sepsis with hypoperfusion, he was in that category that have a 50% risk of death. He was home. So that's a really brief overview. How important sepsis is, why I got involved personally, and what we as a healthcare system need to do about it. Sepsis is everybody's business, whether you're a student or a consultant, whether you're a nurse, paramedic, allied health professional or doctor, we all have a role to play in sepsis. Remember that working together, we can save 12,500 more lives every year. We can shave £170 million off the NHS budget, and we can make survivors' lives a heck of a lot better. As you go through your careers, please think about how you can help the system to fix sepsis. There are lots of clinical toolkits that we've produced as the UK Sepsis Trust in collaboration with NHS England. Ensure that there's a toolkit in your area. If there isn't one available, then ask us to help devise one. Working together in a coordinated, collaborative fashion will ensure that we achieve our goals. I hope you enjoy the rest of the session. Thank you for your time.